Well, how are we going to know whether that epigastric pain, how are we going to know whether that epigastric pain is ulcer disease? Without endoscopy. How can I determine if this pain that you have here is gastric ulcer, duodenal ulcer, gastritis without endoscopy? How do I tell whether the pain in here is ulcer disease or talking to your mother too much on the phone? How do I know what the pain in here is from? How can I tell without endoscopy? And the answer is, I can't. Barium studies are always worse. Barium studies are always worse. So therefore, the only way to tell those apart is with endoscopy. Now, you don't have to do endoscopy to diagnose Helicobacter pylori. You could do serologic testing. Now, what's good about serologic testing? It's extremely sensitive. Sensitive meaning that a negative test rules it out. Sensitive, snout. A negative test rules it out. Negative, snout. A negative test rules it out. Negative, snout. A negative test rules it out. However, a positive test is not very accurate. A positive test might mean that you're colonized. A positive test might mean that you had Helicobacter pylori last year. A positive test might mean that you had ulcer disease last year. A positive test is not very specific. Which of the following is the most specific diagnostic test? Which of the following, if positive, is most likely to include the Helicobacter pylori? Which of the following is the most specific test? The answer is biopsy. This is a very specific test. A positive test rules it in. It's very specific. A positive test rules it in. Specific. Spin. A positive test rules it in. Spin. This, a negative test, rules it out the snout. Now, breath testing changes in response to therapy. Breath testing, if you take your treatment for that Helicobacter pylori, you're going to have better breath than you do right now. If you have the Helicobacter pylori therapy, the breath test will become negative. You'll kill off all the little bugs and you won't have Helicobacter stool in your stool if you treat the Helicobacter pylori. So therefore, breath tests and stool antigen tests respond to therapy. They change with therapy. Watch me, don't get lost on the turn here. Ready? They change in response to therapy the most rapidly. Ready? When do we do a test of cure? You have a duodenal ulcer. I scoped you. I know what's there. I know you got a duodenal ulcer. I know you tried to hide it, but I've been inside you in places no one has ever been, and I have seen the duodenal ulcer, and I have seen the evil that you sometimes have inside you, but I still love you. Well, I've given you the proton pump inhibitor and the 2 antibiotics, and I have treated you with the proton pump inhibitor, clarithromycin, and amoxicillin. I have treated you with clarithromycin and amoxicillin, and I have used a combination of a proton pump inhibitor and 2 antibiotics. A proton pump inhibitor and 2 antibiotics. A proton pump inhibitor and 2 antibiotics. And I have eradicated your disease. When should I do these tests? If the symptoms recur. Persist. Don't get better. But didn't you say persist? Yes, that means don't get better. Recur. Got better, came back. Recrudesce. Got a little better, then it got a little worse. Recrudescence. Not all the way better. Got a little better, and then recur. Ah, I feel good. 2 months later, oh, I'm in pain again. Persist. Medications? I'm still ing. Recur. Recrudesce. Persist. That's when I do. Recur. It got better and got worse again. Recrudesce. It got a little bit better and then worsens some more. Persists. You did nothing for me. That's when you do these. They change with therapy. When should we do a routine test of cure? Never. When should we do a routine? But you just said these could be used to test cure. Yes, that's true. So when do you do a routine test of cure? Never. But stop that. No routine tests of cure. Okay? They could be used, and they do respond to therapy. I treated you 95%. 90 to 95% should be cured. Now, if this was oncology, we would say sustained remission. But infectious disease people are, by nature, more happy, more optimistic, and have better pectorals. So therefore, we say cure. 90 to 95% cure. Now, what about those other 5%, 5 to 10% where they fail therapy? What about the 5 or 10% where they fail therapy? Breath test and stool antigen. Those 5 to 10% when they fail therapy. Maybe they're resistant to clarithromycin and amoxicillin, and we should switch the antibiotics to the other antibiotics, metronidazole or tetracycline. Now, Dr. Fisher, why didn't you say metronidazole and tetracycline before? Because they're not as effective as clarithromycin and amoxicillin. Not as effective. Effective. Infectious disease, effective. Infectious disease, effective. Infectious disease, effective. Infectious disease, effective. Effective equals sensitive. They're not as sensitive to these drugs. Helicobacter pylori. If you go out on the street and you just pick up any random 100 Helicobacter pylori, hey, yo, come here. And you pick up any 100 random Helicobacter pylori, you're out on the street, you're having unprotected contact with a gastric mucosa that you don't know, and you're just picking out 100 people and having unprotected anonymous contact with their gastric mucosa. There are going to be more people who have resistance to metronidazole and tetracycline compared to these. Now, for those of you who may have studied some GI before, it may have been that in the past you had heard about using things like H2 blockers, ranitidine, famotidine, nizatidine, cimetidine, ranitidine, famotidine, nizatidine, cimetidine. They're not as effective as H2 blockers, and it has become clear that this regimen of any of the proton pump inhibitors, remember any of them, and later on I'm going to, you know what? I think I'm going to do this. Let's switch this down here because I want this random. I want it random because I want to emphasize here that no matter, even though you may be giving up yourself for a piece of pizza and a pen light and a new pen, these drugs have equal efficacy. These drugs have equal efficacy. Any one of them, and these two antibiotics is the best. What happens if it worsens or doesn't get better? How do you know if they failed therapy? Breath testing or stool antigen. What's the most specific? Biopsy. What's the sensitive test? Serology. Negative serology? No Helicobacter pylori. How can I tell the difference between duodenal ulcer and gastric ulcer without endoscopy? In the past, you were told that food made duodenal ulcers better and food made gastric ulcers worse. If food makes it worse, that means that these patients tended to lose weight loss. To lose weight, and these people did not lose weight. No weight loss, or in fact, weight gain. Now I know you may be thinking, I'm going to get a gastric ulcer as another form of weight control. You're thinking that maybe that you can use Dr. Fisher's special tape for weight loss. This is a special tape you can use. Use my special tape 3 times a day, Dr. Fisher's weight loss tape. It accompanies this video. You ready? You get the tape. It's duct tape. Weight loss tape 3 times a day. You take the tape, you apply it over your mouth. And 3 times a day, the weight loss here is because you're progressing to cancer. Yes, there's nothing like death to slim you down. The ultimate slim fast diet. Death. Gastric ulcers. 4% go on to cancer. This thing about food, better or worse, is a gross approximation only. Should I scope based on this? No. This is an isolated factoid. It doesn't change it. You scope based on this. If you're over 45, everybody gets scoped because the incidence of gastric cancer starts to peak up a little bit at 45, ever so slightly. Would you allow yourself to be scoped for a 1% chance of cancer? Yeah, you would. Do you play the lottery tickets with a 1 in 1 million chance of winning? People do it all the time. So even at 1/10 of 1%, people would start to get scoped. This is how you're going to base your endoscopy. Patients over 45 or patients at any age who have alarm symptoms, weight loss, blood in the stool, anemia, dysphagia, oh my God, scope me. That's alarming. This is an approximation. You can't distinguish the pain here of gastric ulcer versus duodenal ulcer versus gastritis versus non-ulcer dyspepsia without endoscopy. Barium studies are not as good. You scope even to exclude cancer. I can diagnose Helicobacter pylori with serology, breath testing, and stool antigen. Why do I scope? Because I can't biopsy. What's the best initial therapy for ulcer disease? Any proton pump inhibitor. If it says Prazole, it's good for you. Combined with 2 antibiotics. The best 2 antibiotics, clarithromycin and amoxicillin. Very small failure rate of this regimen. What do you do if it fails? Switch antibiotics and test for cure. Switch antibiotics and test for cure. That's what you do if the person fails therapy. Now, in general, what causes you to have ulcer disease? The causes of ulcer disease is like the causes of gastritis.